Hello, I'm Dr. Brenda Smith. I'm a clinical psychologist working at Schneck Hospital in Seymour, Indiana.
And I'm Dr. Aaron Bannister, and I'm a counseling psychologist, and I work at Schneck Medical Center in Seymour, Indiana. And today we're going to be talking about depression. And although there are periods throughout our life where we feel down or sad, many people struggle from something a little more severe, and it's depression. And depression is a prolonged sadness where it interferes with daily living and can last an extended period of time. And the National Institute of Mental Health estimate that nearly 15 million adult Americans have a diagnosis of major depressive disorder, with an additional 3 million adult Americans having another form of depression, a milder depression or a chronic depression. And our hope is that today, as we educate about depression, that when you're finished watching this video, you'll be able to understand a little more about what depression is, the risk factors to look for someone who is struggling with depression, and what to do if you or someone you love is affected by depression. The DSM-4TR defines depression. That's our diagnostic manual that we as psychologists use that contain all the mental disorders, mental health issues. And it defines depression, and there's 10 core symptoms that occur nearly every day. The first is a depressed mood. The second is having a loss of interest in almost all activities or events that you found pleasurable before. So that's really feeling like things that were important before or a hobby that really was entertaining to you, now it just doesn't hold much meaning or much significance. Third is appetite change, weight loss, weight gain. Insomnia, where you have difficulty sleeping. And there's different forms of insomnia. Some insomnias, you can't fall asleep when you lay down to go to bed, and that can get very frustrating. Or you wake up in the middle of the night and have difficulty falling asleep, or you wake up very early. And those are three different types of insomnia that someone with depression may experience. Hypersomnia is the other side of that. People who sleep too much. They feel like no matter how long they sleep, they don't feel rested. They just want to stay in bed. They have a hard time getting up. Some people feel extremely fidgety, and some people feel very slow. They feel like they're moving in a slow manner, speaking in a slow manner, that typically they may not move in that way. Another symptom is a loss of energy or fatigue. They just feel very tired. They feel drained. They feel like maybe their battery's on empty and they're unable to move forward. People struggling with depression a lot of times have feeling of worthlessness or excessive guilt. They find themselves ruminating on situations that have long been resolved, or they can't, it's almost like going down the river and getting snagged on something. They just can't move past what it is that their mind is fixated on. People have difficulty with thinking, concentrating, or decision-making. They feel like they're just not processing things as quickly as they had before. They have difficulty making decisions. One of the more troubling symptoms to a lot of folks is that when they're struggling with depression, they have recurrent thoughts of death or suicide. And that doesn't mean that they're actively looking to end their life, but they may think about their own death. They may think about what it may be like to die. Who may come to their funeral. They just really think of death in a different way than they would if they weren't depressed. Some people become suicidal, and we'll talk a little more in this video about how to assess for that and what to do there. And the 10th core symptom laid out in the DSM-4TR about depression is a preoccupation with somatic symptoms or physical pains. They become preoccupied with their health status or physical limitations. And a lot of times, especially with older Americans, they're more likely to go to their primary care physician because they think they have an illness than to come and see a psychologist or a mental health professional to work towards depression or resolving that depression. And a few facts about depression is that 50 to 60% of individuals who have experienced a single episode of depression are likely to have a reoccurrence of that depression within 2 years. About 15% of individuals with major depressive disorder die by suicide. The percentage is far higher of people who attempt suicide, but those who complete the act, it's around 15%, and that's a very high number. Depression is twice as prevalent among adolescent females and adult women than it is males in the same age group. But that statistic is a little misleading because males are far underrepresented in this group. Men, a lot of times, whenever they're struggling with depression, they're less likely to reach out and ask for help. They're less likely to confide in their doctors that they're struggling with something concerning their mood. The National Institute of Mental Health estimate that 6 million men are affected by depression, and a very low percentage of those men actually seek treatment.
I'd like to speak to you about the general risk factors for depression. Depression has both an environmental and a genetic contribution. If you have a parent who has major depression, a biological parent, you have a higher degree of likelihood of contracting depression. If you have environmental stressors, you have a higher likelihood of having depression. And there's an interesting reciprocity to that, in that depressed people tend to see subsequent situations as being more depressive and more stressful. That depression both makes us vulnerable to stress and is more likely to occur when we're under stress. So there's a constant feeling of being depleted. Stressors that often can trigger depression are losses, a loss of a job, a loss of an important relationship, loss of health with a chronic condition. And in fact, two of the things that make it more likely that you'll contract depression are another mental illness or of another physical condition. There's a lot of constellation of the suffering symptoms pulling together. Depression affects different populations differently, and two populations that we wanted to speak to you about today are depression among women and depression among the elderly. Depression affects women particularly at stages within their lifetimes, and particularly at stages that are affected by hormonal conditions. Adolescent females are at highest risk for a depression episode just when their menses begin. It's a very changing time in their lives. Their identity is shifting, and their chemistry is quite unstable, and that often leads to depression. Women during pregnancy and women during menopause. There are some characteristics that also put them at risk for depression. If they're more likely in their personality style to be dependent or passive, they'll have less of a sense of control over the world, and that makes them vulnerable to depression. The more children a woman has, the more likely she'll be depressed because it adds more stressors to her. There's a particular form of stress for women that leads to depression, which is called postpartum depression. Postpartum depression occurs within 2 weeks after the delivery, and it's very different than the baby blues. Nearly 5 to 8 out of 10 mothers during the first week after delivery are apt to have some mood swings, some tearfulness, but that's not depression. Depression, especially postpartum, usually occurs 2 weeks after the delivery, and it tends to include those neurovegetative signs that Dr. Bannister was talking about, the sleep disturbance, the appetite and energy disturbance, as well as the cognitive or the thought symptoms of depression, negative thoughts of themselves, negative thoughts of the world in general, and negative thoughts of the future. That's Beck's negative triad of depression.
The next piece that we want to talk about in awareness of depression is maybe one of the more uncomfortable pieces, and that's talking about suicide and suicidality. It can feel very awkward whenever you're initiating a conversation with someone you care about or know about if they're having thoughts of death or thoughts of hurting themselves, but it may be one of the most important conversations you ever have. As we mentioned earlier, one of the symptoms, common symptoms of depression is thoughts of death and feeling maybe that they're better off dead. And it may not be actively wanting to die, but more of a no longer wanting to live, feeling hopeless. And that's some of the things that we want to assess for when we're looking at if someone is just having thoughts of dying, or are they actively suicidal? And we want to talk to them about their level of hopelessness. When you're talking to them, are they talking in language that is future-oriented? Are they talking about what they're going to be doing when the summer comes? Are they talking about what they're going to be doing next week or how a relationship is going? Future orientation is an important piece because it shows that that person is thinking past today and the trouble that they're feeling now, and it instills a little bit of hope there. We also want to look, is that person giving things away to them that are meaningful? Are they giving away significant gifts, and that would be unexpected of them at that time? That might be a sign that they're planning on ending their life and they want to get these special mementos or items to people that they think will care for them, or it shows them that they care about them. In suicide assessment, it's okay to ask the question straightforward, are you planning on hurting yourself? A lot of times folks who are depressed feel like there's no one else who really understands what they're going through. They feel very alone. And when they have someone care about them so deeply that they're willing to cross those uncomfortable waters to ask that question, it can really have a significant impact on the course of their life. It's important to be able to discuss with them the religious beliefs about suicide. Many religions condemn suicide, and for folks who have a spiritual component, they may be feeling like they don't want to live, and there's conflict there because they don't want to commit suicide and break one of the significant rules of their religion. So being able to discuss with them the religious beliefs, the things that morally they feel in that area, can be an avenue of conversation that you can have there. And if you suspect someone is suicidal, being able to ask them by what means would they commit suicide? Do they have a plan? Do they have a place? Do they have a time? And whenever someone is able to discuss with you specific plans, specific actions that they'll take, that's a very, very big warning sign that that person has seriously contemplated it, that it's no longer just thoughts about death and thoughts about what if I weren't here anymore, but that's someone who's been in a more active process of thinking about ending their life. Don't delay in that. If someone shares with you that they're suicidal or that they're no longer wanting to live, you need to take action. And a lot of times maybe we don't take action in situations because we don't know what to do. And if you find that someone is suicidal, then you should call 911 and alert 911 what's going on, or you should take that person to the nearest emergency room so they can get help through that emergency room. Also, if you're having suicidal thoughts, I encourage you to call this hotline. It's the National Suicide Prevention Lifeline, and the number is 1-800-273-8255. And there are people standing by to talk with you and help you through this process that may be confusing and very scary. But I encourage you to call that. And you can also go to their website at www.suicidepreventionlifeline.org. And they're going to have a lot of information there for you if you are feeling suicidal. Also, for folks who are just wanting to help out, you can find some information there on how to become better educated and more aware of suicide and what we can do to help prevent something from happening. A lot of times, in people's despair, they decide to make a permanent solution to a temporary problem. And that's what we want to remind folks of, is that there's more than just today, and that there's hope, and in connecting those folks with the right treatment, the right professionals, people that love them, it will hopefully help them move forward out of their depression and a little bit away from the suicidality that they're feeling.
Depression is treatable. Life can change, and it doesn't take a very long time. It doesn't take a lot of difficulty for the treatment. And one population that's a favorite of mine where the treatment of depression can make the difference between night and day is the elderly population. So many elderly people have suffered several losses of spouse, loss of job, loss of identity, loss of their health. And those losses will accumulate and can create a depression that unfortunately may be seen by their family, friends, and health practitioners as a natural part of growing old. And that's not so. Depression is not a natural aging phenomenon. And in fact, many of the things that we do for care of the elderly can actually cause depression. Medications such as beta blockers, Parkinsonian meds, corticosteroids, antispasmodics, the medications for hyperlipidemia, the medications for acid reflux, those medications can all create a depressed mood. Not to mention several health conditions for elderly people that can create a depressed mood. To have a stroke, heart conditions where you're adding more antihypertensives, to have Parkinson's disease, the other neurological diseases, those often create a depressed mood. Any of the diseases that create a difference in the facial aspect will be sometimes interpreted as depression, whereas it's more neurological than mood. Another condition that's often confused with depression is dementia, and the difference between the two is dementia is a decrease of the mentation or the thinking ability, whereas depression is a decrease of the mood. With depression, you need to remember that there are a triangle of symptoms. The cognitive symptoms, which are the thoughts, often negative, as we said before, about self, future, and the world as a whole. The emotional symptoms, which have sometimes sadness, but often with particularly males, can actually be an irritability or a shortened frustration tolerance, a sense of hopelessness, a sense of apathy, just not caring anymore. And then the physiological symptoms, which we described as neurovegetative, which are the sleep disturbance, the appetite disturbance, the energy loss, the anhedonia, the lack of pleasure in an activity that used to be pleasurable. For elderly people, any history of attempted suicide, previous psychiatric history, all of those things should be asked in any encounter that you have in the care of them, and because there's a state-dependent quality to depression. If you are in another stress situation, you will fall back to the state of feeling depressed. One of the best predictors of whether a person will have depression is, have they ever had it before? History is prologue with the mood disorders. Another issue that often brings about depression is a change of environment. If an elder becomes ill and has to leave their home, or if they lose their spouse and no longer live in their home, that change of surrounding can create a depressed mood. And in fact, we know that depression among the elderly tends to increase by half again by how much restriction there is in the next living environment. So that while they're in the hospital, rather than the 18% of the population of elderly that suffer from depression, you move into about the 24% of the population. Then if they go from the hospital to short-term rehab care, it moves up into the mid-20s, up to the low or the high 20%. Then if they move to a full-time, full-care nursing home rather than the rehab facility, it moves up to as much as 1 in 3 elderly will suffer depression. And unfortunately, depression is contagious. When we treat a person with depression, we know that their family members are going to suffer from that and feel some of the depression as well. In a nursing home where many of the patients are depressed, they'll often make other people feel depressed as well. Suicide among the elderly is often a risk, and it's not usually asked as much as we ask elder or younger people or middle-aged people, there tends to be a real hesitation to ask an elderly person if they're going to commit suicide. And one of the types of suicide that's frequent among the elderly with depression is a giving up or just letting go, not taking their medications, not caring for their diet, not doing the things that keep them well and alive. Dr. Bannister mentioned that the numbers on men and suicide are particularly difficult. Part of that is the way that the patients commit suicide. Females are more likely to commit suicide by overdosing, which will be seen by the medical community often because the female becomes unconscious or unresponsive and is brought to the hospital. Men tend to commit suicide more often by vehicle accidents and firearms. Those vehicle accidents are then seen as an accident, which is often what the gentleman wants to do so that the insurance will be there for the family. So we're not certain that we have our counts right as far as the men who commit suicide.
And I think studies show that females are more likely to attempt suicide, but males are more likely to complete suicide because of the high degree of lethality of the means that they choose to attempt.
Right. What we'd like to talk to you now are some different forms of depression.
Yeah, including major depressive disorder. There were a couple other depressive disorders and a mood disorder that we wanted to discuss and make you a little more aware of. And the first is called dysthymic disorder. And what dysthymic disorder is, it's a low-grade depression that is there for at least a 2-year period. And it doesn't have the severity as a major depression does. In other words, it doesn't always interfere with daily living, but the person tends to be more pessimistic, less hopeful, and because of that, their relationships suffer. They have a difficult time seeing the good in things, and it can just and maybe you know folks like that, where it just seems like they're chronically unhappy, that it's never really an extreme, but they're not really getting the things out of life that they want. They're missing opportunities because they've got this low-grade depression that just seems to hold them hostage. Another disorder that we wanted to mention is something called seasonal affective disorder, or SADS. And what seasonal affective disorder is it's a qualifier or a type of depression. And how it works is that certain seasons during the year, folks experience depression. It's most common to have an onset in the fall or the winter, but it can also happen in the summer, surprisingly so. But when the seasons change, it does something to our circadian rhythm or our internal clock, and we begin to have some struggles. In the winter, it's believed that the change in the amount of sunlight that we absorb has a major impact on our mood. It releases less serotonin in our brain when we don't get the sunlight that we're used to getting. It releases less vitamin D in our bodies, and because of that, someone can have a presentation of depression. They feel very tired. They may become irritable. They crave carbohydrates because when we eat carbohydrates in that time, it can unlock some of those things in our brain that sunlight does. So people may gain weight during that time. And they sort of search for why is this happening if they don't have that diagnosis. They notice that in the winter they feel down, in the summer they feel good. And it very likely could be seasonal affective disorder if that describes you or someone that you love and are around. Some of the other symptoms associated with seasonal affective disorder are some of the same with major depressive disorder, is feeling sluggish, having difficulty sleeping, or feeling tired all the time. And some of the things that you can do for seasonal affective disorder is there's something called light therapy. And you're able to buy a light box, and for 20 or 30 minutes each morning, you sit in front of this bright light, and that simulated sunlight will help unlock the things that in the sunnier months, the sun does naturally. And we also wanted to discuss bipolar disorder. And right now in popular culture, there's really a misunderstanding of what bipolar disorder is. Many people will say someone's bipolar or that they're bipolar because they have a short fuse They can go from being really nice to really nasty very quickly. And that's more about poor coping mechanisms, poor stress management, bad habits. That's not really what bipolar disorder is. With bipolar disorder, there are two different states that a patient or a person will cycle through. The first will be, can be manic, and what a manic state is that's someone who they have a super inflated view of themselves. They can act very impulsively, sexually, spending money they don't have. They don't need sleep. They find that they feel very, very full of energy, may not make great decisions, can become very offensive, and they may not be aware of that. And that is a manic episode, and it can really interfere with daily living and set up a lot of consequences that folks will have to deal with. And then the other piece of the bipolar is depressive episodes. And that is people who, when they're not having a manic episode, will tend then to move more to a depressive episode where they struggle with all the symptoms that we've talked about with depression. And it can be a very confusing disorder for folks to have because they're not asking to cycle through these two different depressive episodes and manic episodes. And we wanted folks to be aware of that because someone who is experiencing depression may also be experiencing manic episodes as well, and they don't cycle through those rapidly. Most folks, it's over a period of a year where they may have 2 depressive episodes, 2 manic episodes, and it can be really frustrating for them because it can interfere in relationships and jobs and education and lots of places. We want you to know that there's help, that you're not alone, that many folks struggle with depression, and that there's help out there. It's important for you. One of the best decisions I believe you can make in your life is to find someone who is a qualified mental health practitioner and begin working with them. Now, find someone with a good reputation in the community, someone who knows what they're talking about, who practices from an empirical, theoretical orientation, or in other words, what they're doing has been proven scientifically to work to help people to improve from the depression that they may be feeling. And if you're able to do that, a lot of folks find comfort, they find relief, and really some improvements overall in their life.
It's interesting to think that depression not only is curable, but it can be in your lifetime a blessing in the skills that you will learn in dealing with the depression can help make you more effective, more self-sure of yourself as life goes on. If you're looking for a clinician for help, I would suggest talking to your primary care physician, checking at your local community mental health center, your local hospital, the 211 or information line in your community to call and get information on providers in the area. Talk to your pastor. Your church may have social services within it. Speak to people at your service groups to ask them if they know of someone who's been doing therapy or treatment. Oftentimes you'll be surprised at how many families you know have someone who's dealt with depression. If you're of a college age, don't neglect to check out the health center at the college. Bipolar mood disorder usually strikes at 18 to 25, so it's right at that age when you would be in college. And until then, remember that depression is a change within those 3 areas of your life, that thinking, physical feeling, and emotional feeling. And a small protocol that we use very frequently in our therapy is John Lewison's protocol of 3 interventions you can do without any cost and which are very effective to changing mood. The first is to exercise every day. As little as 5 minutes in the morning and 5 minutes in the evening will change your own opiates, your own endorphins, so that you feel better both physically and emotionally. The second is to do an act of kindness anonymously for someone else at least once a day. This has a 2-fisted punch to it in that it both gives you that recognition that there are people who need things that you have that are worse off than you, and that you have the power to make someone's life better. If you can do that for someone else, you can do it for yourself. And the third is to adopt an attitude of gratitude, to look at your life, the people that are in it, the things that are what's important to you, and each day before you end the day to think of 3 things for which you're grateful that have occurred to you during that day. And we hope that at least one of them is an opportunity to have individuals like ourselves to provide you information that will help you cure your depression. Thank you.